Hello, I'm Dr. Damien Lafferty, a surgical podiatrist. This session is part of my educational series on chronic plantar heel pain with a primary focus on plantar fasciosis. I'll discuss Baxter's nerve entrapment in more detail later in the series. Today is a general discussion on interventions. Heel pain affects up to 10% of adults at some point. While many cases resolve, a significant number become persistent and disabling. Understanding why that happens is critical to managing it effectively. Clinically, the challenge is identifying the dominant pain driver. Is it plantar fasciosis, Baxter's nerve entrapment, fat pad atrophy, bone marrow oedema, a calcaneal stress fracture, or a large heel spur? Each requires a very different treatment strategy. The term plantar fasciitis is misleading in chronic cases. In the first 6 to 8 weeks, we see inflammatory microtears at the fascia's insertion. Beyond that, histology changes. We see collagen disorganization, fibroblast hypertrophy, mucoid degeneration. This is plantar fasciosis. It's not inflammation, it's failed healing. The tissue becomes poorly vascularized and mechanically weak. That's why anti-inflammatories and steroid injections often provide only short-term relief. At this stage, treatment must shift from reducing inflammation to stimulating regeneration. A thorough assessment is essential. Clinical palpation helps differentiate pain sources. Pain just anterior to the heel bone suggests plantar fascia involvement. Burning or radiating medial pain suggests nerve involvement. Ultrasound allows us to assess fascia thickness, partial tears, degenerative change. High resolution, dynamic ultrasound has completely changed how we practice. MRI is useful in chronic or atypical cases to assess bone marrow edema or soft tissue entrapment. Diagnostic nerve blocks can confirm Baxter's nerve involvement. The key message is simple. Management must be structured and progressive. Step 1. Load management and biomechanics. This includes custom functional and cushioning orthoses, reducing plantar fascia tension, supporting the medial arch, calf stretching, intrinsic foot muscle strengthening, addressing prolonged standing or weight load where relevant. Step 2. Regenerative stimulation. Options include extracorporeal shockwave therapy with strong evidence for chronic fasciosis, dry needling, prolotherapy, platelet-rich plasma injections, particularly for intrasubstance tears. Step 3. Pain modulation. This may include footwear modification, topical agents, short-term immobilization in selected cases. If pain persists, neuropathic causes must be reconsidered. Baxter's nerve, a branch of the lateral plantar nerve, can be compressed beneath the abductor hallucis or against the medial calcaneal wall. Patients often describe burning or tingling medial heel pain, pain that worsens throughout the day. This is the opposite pattern to plantar fasciosis. Treatment may involve orthotic offloading, targeted physiotherapy, image-guided injections, or hydrodissection. In refractory cases, surgical decompression may be required. Importantly, recognizing Baxter's nerve involvement prevents years of ineffective plantar fascia treatments. Surgery is typically reserved for fewer than 10% of patients who fail structured conservative care over 6 to 12 months. In my experience, this number is now much lower due to ultrasound-guided prolotherapy and PRP. Where surgery is indicated, options include plantar fasciotomy for mechanical fasciosis, nerve decompression. If entrapment is confirmed, heel spur excision if bony impingement is significant. In summary, chronic heel pain is multifactorial. Plantar fasciosis is degenerative, not inflammatory. Baxter's nerve entrapment is neuropathic. Successful treatment depends on identifying the dominant pathology and applying evidence-based regenerative strategies rather than repeated anti-inflammatory approaches. Thank you for joining me. I'm Dr. Damien Lafferty, surgical podiatrist. This reflects my personal opinion, developed over 12 years of education and nearly 30 years of clinical experience. If you have questions, please feel free to ask.